Hi, I'm Doug Barry, a principal with Mazars in the healthcare transformation practice. With me today is Cheyenne Holland, managing director in our practice, and we're here today to talk to you about what we see as some of the most pressing issues for our clients. So, Cheyenne, I know you've been a hospital CFO for over 20 years before joining Mazars, and you've weathered a lot of storms. But the magnitude of the losses we see today in hospitals and health systems, what they're facing is really unprecedented. And operations are significantly impacted by shortages in workforce, and organizations really are frankly trying to keep the doors open and the lights on. So we see a lot of hesitation around kicking off an operational turnaround strategy. So what do you think the steps are that an organization should take, when they're trying to initiate a real strategy to turn operations around?
Thank you, Doug. Yes, there's been a lot of upheaval in the industry in the last couple of years. Post-COVID, we're seeing these severe workforce strategies, and I know many hospital leaders are just trying to get through day to day. When an organization is looking at a full turnaround, they need to look at actions that are going to take a longer term sustainable approach. So it's not a one and done quick, a quick cut where it could likely rebound later. So the first step is to look at those areas that they need to focus on that can create long-term sustainable improvements. The other suggestion I would have for an organization is, as they're looking at the sustainability and turnaround activities, is they need to adopt a formal performance improvement methodology. It doesn't matter which methodology they choose, whether it's like a lean or something like that, just so that they have a way of measuring their success, putting the rigor in place at the organization to hold one another accountable for making the sustained changes that they need to make.
So, that brings up a question that I have for you, Cheyenne. We talk to a lot of leaders and they seem extremely overwhelmed. There's just been a lot in the industry for the last couple of years. So, we know that some of these opportunities take a great deal of time to drive home and others maybe not. What are some of the quick wins that an organization can embark in that direction to have immediate impact?
Yeah, so the first place I would look at for quick wins in today's environment is on the top line. Look at the revenue. Where can you either capture revenue for and improve the revenue and collections for the work you're already performing, looking at what services you provide, see if there's ways to get more volume in, and just really the quickest wins are on that top line. Cuts, are counterintuitive. You look at making cuts in your expenses, you do staff reductions, and then you have that inability to meet the needs and provide the services necessary, or to do it effectively and efficiently. A lot of times when organizations try to make a quick cut or a quick reduction, they cut areas that could have a negative impact on their future ability to generate revenue. So I would look first at the top line revenue.
That makes sense. Between the two of us, we have over 75 years experience in this business, and it's painful to see a good plan move forward only to shelf it and come back 3 years later and they're in need of the same. So what are the attributes of a financial and operational sustainability plan? Because it's all about sustainability.
Yes, I think that the key attributes are first is adopting that performance improvement process. Like, what are you going to adopt within the organization? What methodology are you going to use to really track changes made, track the success, go back, reevaluate all the process changes that were made, and be able to evaluate that. The key, I would say the number one key attribute that a plan needs to have is an accountability structure. a lot of times there's a lot of great ideas, and people, in the organization, they get really excited and fired up, and it's everybody goes forward right off, getting lots of great results. And then what happens is they lose some momentum because there's another issue or another fire that needs to be put out in the day to day. With an accountability structure, the organization is then really kept, and this is their true north, so to speak. This is what we're looking to do. This is our long-term strategies and goals that we know we need to become fiscally sustainable in order to provide the services that we need to provide to our communities.
So Cheyenne, that answer was really on point, and I think it's important for providers to really adopt a process that's going to be successful. One of the things that I think is important also is being able to give leadership sort of a roadmap of where they don't want to go. So, what are the common mistakes that you see leaders making when it comes to margin improvement and doing turnarounds?
Yeah, so the common mistakes that I see is, first, not having an accountability structure, not having those clear goals outlined and a way to measure the performance. One of the other things that I see, and our industry, healthcare industry, has so many data points. I see data analysis paralysis, where there's a lot of trying to get to that best possible number, and is it 100% perfect, instead of kind of taking a step back, saying, what is this data telling me, and can I take action on it? One of the third thing I would say is there's often an over-reliance on benchmarking when organizations start and they kick off a performance improvement initiative or a margin improvement initiative. Benchmarks are great for setting sort of a goal or a standard, but everybody there, first of all, the data is delayed, so you're not necessarily taking into account other updated metrics, and you're not necessarily comparing yourself to organizations that are at the highest performance. You're comparing yourselves to those that are likely struggling in the same way. And so I would take approach of, let them guide you as an area where you may want to spend some focus, but don't over rely on your benchmark. We've seen it in some of our work with clients where they may look good on the benchmark, but they're still losing a significant amount of money. So even getting above median or getting above the top, decile in performance is a good goal to have in order to realize those improvements.
All good points, because I've seen the same in terms of an over reliance on what the industry says as a benchmark, without paying attention to the fact that almost every entity gets that number a different way. And no one likes to look like they're performing poorly. So there could be a great deal of creativity around the final result. So a very, very good point.
Thank you, Doug. So you and I have worked together for quite a while now, Doug. First, I was your client before I joined the Mazars team, and you helped me and my hospital where we met in implementing a lot of great revenue cycle improvement initiatives. Getting back to what I was saying about where to start, it's starting at that top line. So hospitals frequently money on the table because of poorly documented records and disparate EHRs that may not be talking to one another, and documentation in multiple locations. What type of revenue opportunities do you typically see, and what can organizations do about capturing this?
That's a good question. It's an actual, for my career, has been one of the areas where the money is sitting right there and no one is going after it. And it's a lot broader than just the money. So most hospitals are focused in on a handful of high volume DRG payers, the governmental payers. They're not expanding that review to include all of their DRG payers or their uninsured patients that are being converted to DRG payers based on advocacy programs that are in place in the front end. I've seen anywhere from $5 to $25 million for hospitals that are 200 to 500 beds, just from expanding those programs, especially those hospitals that are in those geographical locations that serve a great deal of the poor and needy. It's amazing to me that the folks that work in quality in an acute care hospital aren't better connected to the folks that work in HIM and CDI, because the absence of those reviews is driving a lower quality metric, and the hospital is unfairly being portrayed as providing poor service or having a higher risk and mortality rate than really could be justified if it had been coded and documented properly. So it's not just the millions of dollars they leave on the table, it's accurately portraying good quality care, where the numbers may not reflect that, and people look at those numbers.
Yeah, you're right. And because there's so much of that quality information comes from the same exact documentation as the reimbursement data, that if there's missing data, it could put a hospital in a poor light when in fact they're providing excellent care. So we talked earlier about some of the challenges hospitals have around staffing and labor shortages, and I know many facilities are looking to perhaps outsource some of their services, some of their back office functions, their billing, their coding, their revenue cycle, accounting services, things like that. With that comes working with these vendors to provide that service. What kind of quick wins when it comes to vendor management do you see in the revenue cycle space?
This is an emerging opportunity that is probably secondary to the clinical documentation, one of the biggest opportunities that we find. Many vendor contracts have been in place. They're long-term relationships. They don't represent the actual cost for that vendor today to be able to be much more efficient and provide that same service for a lower rate. Hospitals are very poor at renegotiating and holding their vendor to the new technological ability they might have, where they know their costs have gone down significantly to process the hospital's business. So it takes an ongoing partnership, and we don't see that. One of the things, as you know, Mazars has an outsourcing arm with the built-in consulting approach, so that if you're outsourcing business because your resources aren't sufficient to process it in-house, your partner should be helping you identify what you can do differently to reduce the need and the amount of work you need to outsource. And I think that's lacking, as these vendors that we see are typically more interested in the margin and the profit on their end. An example of that is most hospitals do not have adequate staffing to work their small dollar, high volume accounts. They just can't get to those. But what they don't take into consideration is that most hospitals have a fairly high claim rate where it's clean and ready for the payer to adjudicate the case. Handing those to a vendor is simply handing free money, because much of that would adjudicate by itself. So it's a look at the timing of placements, it's a look at the rates they're being charged, it's a look at the capabilities, and it's also a look at the relationship. Are they a business partner? Are they doing everything they can to help the hospital save money? And those are the key things we look at when we do vendor management assessments.
And they may also have issues with recruitment and staffing and education and educating, an ongoing education and training of their staff. It just like a facility may.
In fact, frequently we hear, and you can look through websites like Indeed, and where people talk about their employers and rate their employers. Some of these vendors apply a great deal of pressure They don't have all the same resident HR coverages and activities and training that a hospital has. And so, frankly, you see a lot of turnover. And to assume that just because they're a big firm, your business is going to get the same level of attention as if you did it in-house, it's not always accurate.
True, that is true, because they're not immune to a lot of the same staffing challenges as anywhere else. When you're working with your clients and you're looking at how to grab and capture that top line revenue, are you seeing that there are uh, any benefits or any wins by looking at the charge master, looking at the charge capture process, and what can be done to improve revenue recognition?
So that's a good question because in this industry, the people who look at the charge master itself have been doing so for 20 years, and the value is sort of minimal compared to what it was in the initial stages. What I think people miss the most, and what we do differently here at Mazars, is we recognize that in the complexity of the charge process, you have multiple systems that are maintained by multiple individuals in multiple departments. Those departments have to accurately build so that the connectivity between their department and the charge master, which ultimately drives billing, is 100%. And what we find when we do the data analysis is frequently there are gaps in the connectivity, which could be $3 to $5 million of revenue that they are not capturing. And the way that we approach that is to look at their revenue and usage and understand the types of services and surgeries, and knowing what should be a part of that bill, and seeing that it's not being used on the charge master, or seeing what's on the charge master and those surgeries that should be connected to that, and finding out that it was never tied in the order entry process over at the department level. So it's not a lack of performance. It's a complex, voluminous entry into the order entry system, and you have to connect that and parallel that with individuals that you don't even know who are maintaining that from a revenue integrity perspective. So it's a natural breakdown, the degree of which can vary, but it's new revenue and it's recurring revenue, and it's an exercise that's extremely valuable for hospitals.
And how often would you recommend a hospital to take a look at their charge master?
It should be done annually for many reasons. There's always going to be regulatory changes that will eliminate, invalidate, or need to, require you to add. That happens annually. But in addition to that, there are several items, preference items, and new devices, and new drugs, and all of these things are built on the fly in the order entry piece. So they have to continually be validated that they're flowing correctly over to the charge master.
That's great. That's good to know. So we're seeing a lot of pressure in our industry, in the healthcare industry, economics, the local, an individual's ability to pay for their portion of their insurance, the self-pay portion of their bill. That's always been a struggle for hospitals. Hospitals are in the position of providing care. They're not always good about asking for cash up front or for payment. What are the attributes of a good point of service collection program if an organization wanted to really step that process up?
That's a great question, Cheyenne. I've always been just fascinated by the lack of accuracy in how we gauge the performance of front-end employees and when it comes to cash collections. So many hospitals are simply tracking the dollars collected. What they should be tracking are the dollars collected for those patients that had an opportunity to pay. And not everyone does. And not every patient can pay. And not every patient has the ability to pay at the time of service, or should when there's an unknown amount. So what really needs to happen is folks need to understand how many patients could have paid in a given week and how much of the money was collected against that population. And that's really what's meaningful. In addition to that, there's a great deal of patients who are rolling off at the end of the public health emergency that are moving off of Medicaid and Medi-Cal enrollment. And many of them, through the re-eligibility process, could retain benefits, but that's going to take advocacy on the part of the provider. Another problem I see in point of service is many patients who use the emergency room when it comes to collections are there as a result of accidents. There's other liability, there's workman's comp, and those are two areas that I think access misses the most. We all know the folks who come in with insurance. We all have products in this business that can help us screen for eligibility for commercial payers and Medicare and Medi-Cal. But it's those uninsured people where there is a liability and a third party that should pay that bill that gets missed frequently. So there are many patients that are sitting in the self-pay bucket that are truly have a source payment. And so I think what hospitals really need to do in point of service is, in addition to focus on do you owe money and do you have the ability to pay us today, is thinking a little bit broader and understanding why are they here today? What could a potential source be? Are there charitable funds for that particular diagnosis? Are there organizations that fund that diagnosis? Because there's a myriad of opportunity and payment sources that just have to be connected. And it's much broader than this is what you owe the hospital, can you pay?
That's all great advice. And I've found it fascinating that in our industry, we are hesitant to ask for cash up front, although most individuals, they go and receive a service, they expect to pay something, they know they have a copay, and really patients walk away saying, oh, I'm surprised they didn't ask me, so I think
I can tell you, I have never been able to get in to see my primary care physician without someone saying, this is what you'll pay today. How would you like to do that?
Absolutely.
So I
Absolutely.
agree. This has been a great discussion. I know there's so much more we could talk about, and as a firm, we've been helping so many hospitals navigate through the storm, but it can be done, and people just have to start thinking a little bit differently and a little bit out of the box, and it's an industry that will always face storms, will always be overregulated, and always face challenges. So it's just you have to be nimble, you have to be ready to change gears and think a little bit differently than we have historically. So thank you for joining us today. We appreciate your attendance and look forward to the next one.